All right. Good afternoon, everybody. Thank you all for joining us today. Welcome to the National Association of EMS Physicians Town Hall Series. My name is Jose Cabañas. I'm president of NAEMSP and chief medical officer here at Wake County Government. In this role, I also serve as the medical director for the Wake County EMS system. Thank you so much for being here today. This series of town hall meetings are designed to engage our membership and other participants to share valuable information that may assist each of us in our journey of providing high quality care to our patients. In today's episode of this series, we want to facilitate a conversation about the future of healthcare reform after the public health emergency and to talk about what it means for the EMS industry. As you all know, the disruptive forces from the pandemic have had a significant impact on the healthcare delivery system and has highlighted the need for healthcare reform. Reimbursement reform continues to be an important issue for all of us in the EMS industry, and it affects our ability to provide high quality care to our patients. Despite the disruption that we have seen over the last several years, the EMS industry continues to push forward with new innovative approaches to provide service delivery, including expansion of community medicine, MIH, or implementation of the ET3 model. During this session, our panelists will discuss the current healthcare landscape, including what innovative programs may be here to stay, and share a bit of insight into what future reform may mean for EMS systems. Joining us today is a distinguished panel, and I am grateful they're here today. First, I want to introduce Dr. Jonathan Oberlander. He's a professor and chair of social medicine and professor of health policy and management at UNC Chapel Hill. His research and teaching interests include healthcare politics and policy, healthcare reform, Medicare, and American politics and public policy. His recent work explores ongoing political fights and tensions over the implementation of the Affordable Care Act, healthcare cost control, Medicare reform. He has commented nationally in many outlets about this issue, so we're very glad to have him here today. Thank you, Jonathan, for being here today. We also have Randy Strosek. He's been a leader in EMS for more than 40 years and is an integral part of the AMR executive team. He is senior vice president of executive operations, and he's engaged in many aspects of operational aspects and also involved in national advocacy around EMS. He actually has an extensive knowledge of EMS operations, both in the United States and other parts of the world. And he's a longtime member of the American Ambulance Association, who is a co-sponsor of this event today. And he is the incoming president for AAA. Randy, thanks so much for being here today for this conversation. Thank you. Dr. Lakshmi Kumar, she's an associate professor of emergency medicine at Emory, University School of Medicine, and also an EMS physician for Emory Healthcare. She currently serves as the medical director for 911 in the Metro Atlanta region, and she focuses on clinical operations and community paramedicine. Dr. Paul Hinchey, Chief Operating Officer for University Hospitals in Cleveland, Ohio. He serves as the executive leader for the community markets with responsibility for operationalizing the System EMS Institute and service line strategy while overseeing business development and financial performance. Dr. Hinchey has extensive experience in EMS, but also in healthcare operations, and he has been in healthcare for more than 30 years. Sir, thank you for being here.
Pleasure.
Larry McMillan is our Chief Compliance Officer and ET3 project lead for the Wake County EMS system. He's responsible for ensuring adherence to all sources of governance that affect daily activities of the EMS system here in Raleigh. And he has been leading the implementation of the ET3 model from CMS here in our community. Larry, thanks so much for being here today. Dr. Melissa Crow is assistant professor of emergency medicine at Washington University in St. Louis. She's NAEMSP's immediate past chair for the Mobile Integrated Healthcare Community Paramedicine Committee. And she's an emergency medicine EMS physician recognized as a national expert in community paramedicine and alternate destination models for EMS. Thanks so much for being here, all of you today. So let's start this conversation, which I was very looking forward to with the rest of the participants is with Jonathan. Jonathan, you've been here today and you're a national expert in healthcare policy. Can you help us start this conversation around what's the actual overall picture of where we are in the healthcare reform? What are the challenges? Where are we heading? I mean, in your overall picture in this space, what are we sort of heading right now?
Yes, thank you for the introduction, and it's good to be with you all. I spent the early morning hours today outside our DMV here in North Carolina trying to get my license renewed. I can almost feel my fingers again. We're almost to that point. So It's good to be here. And I'm gonna try and share a few slides if I can. Let's see. Okay. Jose, can you see that? Yeah, okay, great. All right, so I've got, I don't know, 7 to 10 minutes to explain you where we are in US healthcare. And one of these days, I'd love to give a talk that when something like this, we've taken fundamental action and adopted major reforms and we fixed all our problems. I've been doing this for a long time. That hasn't happened yet, but I'm eternally optimistic. So where are we right now? Where might we be going briefly? So let me just start out with some good news, relative good news, that is. And that is about coverage in the United States and health insurance. And if you look at this chart, you can see back before the Affordable Care Act was enacted, or around the time it was enacted in 2010, we had about 48 million Americans without health insurance. And during the first decade of the Affordable Care Act, about 20 million people gained health insurance coverage, which is a lot. Given everything that went wrong with Obamacare, and there's a lot, of course, that went wrong and continues to go wrong with it. And there's a growing amount of research that folks who gain health insurance actually get health benefits. And for example, there's reduced mortality in low-income populations in states that expand Medicaid eligibility. So we know health insurance is so important for people. And what I want to call your attention to is what's happened since 2020. And when the pandemic began, a lot of us, including me, were really afraid that the uninsured population in the United States would go up substantially during the pandemic because the economy shut down, so many people lost their jobs. That has not happened. Actually, remarkably, the uninsured rate during the pandemic has gone down. And that's an unexpected result and a good result of, we still have, as you can see, over 26 million persons in the United States without health insurance. That's not good. But the fact that we not only held steady, but went down during the pandemic is good news indeed. One of the major reasons the uninsured population actually declined in the last couple of years has to do with the public health emergency that is the subject of today's panel. And what happened was when COVID came in spring of 2020, Congress passed a law and they said to the states, we'll give you a bunch of money to deal with the pandemic, but in exchange for that money, you have to change how you operate Medicaid, and you can't kick people out of Medicaid. You can't redetermine their eligibility, which is something that happens normally. Partly for that reason, Medicaid has grown tremendously since the pandemic. In the last couple of years, Medicaid enrollment has increased by 20 million persons. There are now over 90 million Americans who are in the Medicaid program. And some of that increase is due to people losing their jobs and becoming newly eligible for Medicaid. But a lot of it, probably most of it, has to do with that rule, that law the federal government passed, that states could not redetermine eligibility. And it's probably the single most important policy to boost health insurance coverage in this country that nobody has ever heard about. We still, of course, have a situation where Medicaid is not expanded in all states. And I'm very happy to report that here in North Carolina, we just in the past week have reached agreement after a decade plus of partisan fighting about Medicaid expansion. And North Carolina is going to be shaded blue when they do a new version of this map in a couple months. But we still have a lot of states that have not expanded Medicaid eligibility. And of course, states like Texas and Georgia and Florida, that's where a lot of the low income uninsured population in the United States lives right now because they have such restricted coverage options. And I also want to point out there are a lot of health equity implications because the populations in those states that would benefit from Medicaid expansion and that are currently uninsured are disproportionately Black and disproportionately Latino. One other thing really briefly, we talk a lot about the uninsured. It's really worth pointing out, especially given what you all do, that many Americans with health insurance don't really have very good health insurance. They're what we call underinsured, and they're not adequately protected against the costs of medical care. And one trip in an ambulance to the emergency room and hospitalization can set them back thousands and thousands of dollars, and they don't realize it until they experience it. And this is a measure by the Commonwealth Fund of what's happening with the underinsured population. And you know, the headline here is the uninsured population's gone down between 2010 and 2020, but the underinsured population continues to go up and is an issue that probably does not get enough attention. Healthcare spending. How much do we spend on healthcare in the United States? And of course, costs are a major issue. We spend a lot. The last year we have data for is 2021. We spent over $4 trillion as a country on healthcare, $13,000 per person. Gross domestic product's the size of the economy. So this means we spent over $1 out of every $6, almost $1 out of every $5 in the US economy is on healthcare. And the average cost of an employer-sponsored plan for a family is a staggering $22,000 plus. Spending money on medical care is not inherently a bad thing. Next time you see somebody with a heart attack, ask them if they want treatment from 1950 or treatment from 2023. Treatment in 1950 was really cheap, very ineffective.
Did we lose Jonathan?
Healthier.
Okay.
And it's also the case that when we spend this much on medical care, it's unstable, hopefully it's back. When we spend this much money on medical care, it's a strain on the federal government, on state governments, on employers, on workers, and families. So healthcare spending remains a really important issue.
John, I think we lost you a little bit. So let me, if you can hear me.
Down. So again, that is good news, but our baseline spending is so high that it's still an issue. Finally, because I know I'm running out of time here and a minute and a half or less. All right. ACA politics. Well, between 2010 and 2020, neither party got what they wanted. The Republican Party wanted to repeal Obamacare. The Democrats wanted to build on it. What has happened since the Biden administration has come in is they've done what I would call Obamacare 2.0. They've made incremental changes in tandem with the Democrats in Congress to try and make the ACA more affordable, to allow more people to sign up for coverage. Where are we headed? Well, because we have divided government now in Congress, we're actually back to this wall. We're back to stalemate. And just a couple things briefly to keep your eyes on. One is the debt ceiling negotiations between the Biden administration and particularly Republicans in the House and what that means, especially for the Medicaid program. And are there going to be cuts on the table to the Medicaid program? The second, as you all know, the public health emergency is coming to an end. We could have an increase in the uninsured population of millions in the next year if states do not handle the unwinding of the Medicaid redetermination well. And finally, the 2024 election, we're at a crossroads again. I always say this in health policy, but you know, what is the Republican plan in 2024, whoever the nominee is? What is their plan on health reform? What is the Democratic plan on health reform in 2024? Where do the parties want to go from here? We can talk more about that later, but I don't think we know right now. So there it is, American healthcare explained in 10 minutes.
Thank you, sir. Thank you, sir. Very, very helpful. Let me ask Randy here, because what I'm hearing here is we just heard from Jeff, and that, you know, cost containment is going to be at some point on top of the list, given if not the primary challenge coming up healthcare. So we are seeing all these challenges and by many EMS agencies needing to spend more money to provide the service because of everything that's going on. So can you give us a bit of perspective what's happening in the industry and where you see things heading in this context of cost containment, whatever that looks like, because as Jonathan said, we don't have the whole tea leaves yet played out.
Well, that's a really good question. I think the, EMS across the country should stand up and pat itself on the back, to say the least. And I think America owes us a huge, might be. I hope they would recognize what we did from March of 2020 onward. And that 24/7, we responded, all healthcare did. But if you think about it, many communities, we were the safety net. We went and we responded 24/7 across the country. And some of these were large EMS systems, obviously, but then small town America still had healthcare, and we had to respond. Lashmi and Larry and Melissa will talk about things that are really critical to what allowed us to survive by starting, in some cases organized, or some cases ad lib sort of treat and release, because people wouldn't go to the hospital. The challenge that exists, and it's just got worse the other day when the president's budget came out, and he says, well, we're going to save $1 billion on ambulance business by bringing us into surprise medical billing, excluding the fact that we have a national senatorial or government-based committee that's now going to do a research project, or I shouldn't say research, do work on them. Sorry, kind of off a little bit on that. That being said, how are we going to take $1 billion out of EMS and then still continue to grow service? So I think, I'm concerned, our ability to be paid by insurers is becoming more and more difficult. The challenges to bring new people on to be in EMS is harder. Our education system shut down for almost 2 years, and so we've had to backfill from that. And the level of complexity and need has just grown. Just to think the simple thing, we always think in terms of 911 systems, but equally important is the ability to move a patient from a community hospital that's a STEMI patient or a stroke patient and get them to a tertiary facility. The immense amount of savings by not only saving that life, but having better outcomes is huge. So I would say, last week I was up on the Hill at various congressional offices and leadership groups talking about the challenges, and Congress, I would give a great deal of credit to, is understanding that we have, that the EMS system is challenged. What there isn't is a clear answer is what the fix is going to be. Is it Medicare reform? Is it Medicaid reform? Is it acknowledgement that treat and release, very much what's going to be spoken to next, has to not only be supported, but legislatively understood across the country, so it becomes a unified basis. That's a real quick way of Jose, of not really answering the question, other than saying, in my 40 years, I've never seen us at a more stressed, challenging point. Yet retrospectively, we just came through something that none of us ever imagined we would do. And the performance, the commitment to America was unreal. And we couldn't be more proud.
Yeah, no, that's a great point. And I think there is ongoing work and consensus between all of associations trying to bring this awareness to the right place, because we did play a critical role. We continue to play a critical role still from the effects from the pandemic, but we're in this kind of disruptive time that is being very consequential. Let me ask Paul to come in here. Paul, you have a very unique perspective as both an EMS expert, but also an in-hospital operations expert, and you've seen all these innovative programs that have flourished through the PHE. I would argue in a way to counteract or as a countermeasures of what's been going on, but we're hearing we have to do cost containment. EMS needs more dollars to sort of navigate the current service. What are your thoughts about those programs that have been flourishing in this kind of world we're living in right now?
Yeah, I think, as Randy said, EMS is under duress. I think everyone knows the healthcare system in general is under duress. And that's led to a lot of innovative programs. One of our challenges, like it is for EMS, is staffing the hospitals. And so bed days become critically important because we don't have enough nurses to staff. So health systems, it's sort of forced innovation to do things targeting length of stay and trying to do early discharges, to do things like hospital at home, where we're able to provide those services at home, but have to deliver 2 visits a day. We have to be able to provide PT and OT, and all the things that would be available to you in the hospital have to be available at home as well. And that degree of innovation has created some opportunities. Healthcare systems around the country are struggling basically to try and service these, and many of them are trying to build what is in effect an EMS system to be able to have home care nurses or have people visit at home, facilitate a video visit with a provider. And, that I think creates tremendous opportunity for EMS. I think, I think more directly, these programs are probably going to stay around for a bit. The feds have to avoid, well, what they say is that to avoid an abrupt termination of programs like hospital at home, which is paid for by the feds, we get to bill for it just like a regular admission. They've pushed them all out to December of 2024. Now, there may be some nuances in there that John probably knows more about than I do, but generally speaking, there are so many of these programs that came along with the pandemic. These are going to be pushed out to 2024. So they're, and I think my own suspicion is that the reason they've pushed it out to 2024 is the feds don't know what to do with this. So many of these programs have been extremely popular. They have challenges about making sure that we still have access, that people still have access across the country. Many of you are not surprised to hear with all the hospital closures, that access piece is becoming more and more challenging. So the feds are very interested in that. But they're also worried about cost containment. As Jonathan said, that the costs are skyrocketing, and the feds are very worried about, will this increase utilization? So far, that was the fear behind telemedicine, which really hasn't materialized. Everyone was afraid that the access would create this overwhelming demand and everyone would just spend healthcare dollars like crazy. That really hasn't happened. Utilization of telemedicine has gone up, but overall utilization of healthcare has not. So that's viewed very favorably. The flip side, though, is the feds, as everyone in the ambulance business knows, they're always afraid of fraud and abuse. So they don't quite know how to manage, there's this demand for it, but they don't know how to manage the potential for fraud here. So I suspect they've pushed this out to 2024 to figure some of these things out, because there's so much demand for these services. They just want to figure out how to do it properly.
That's helpful. And I think the sort of the unknown is the hard part, right? The unknown of where this is going to land. If I think the hard part for all of us in the industry to sort of figure out where we're going to be at. Let me ask Larry.
Sorry, Jose, can I just one more thing, because if people are worried these programs are going to go away, the bigger piece is the shift to value and the movement to Medicare Advantage and capitated models where health systems are paid on a capitated basis on a per member per month. That frees up how care is delivered. So that makes all of these programs, like managing people at home and in other environments, very, very popular and very attractive. So even if some of these programs that came with the PHE go away, the shift to value and the shift to Medicare Advantage in particular is really going to drive this. It's going to be here to stay. So that opportunity will continue to live on.
Okay, that's interesting. And
I just want to throw in, sorry to do this to you, Paul, but I will also throw in, it's imperative, though, as these programs develop, that they understand that EMS, the ability to transport these patients, the ability to provide this care, is not a commodity. We are part of the healthcare system, and I sometimes worry that we get lumped in with pick whatever it may be, and that this level of skill that our next three folks will talk about is an imperative part, and that we're not discounted or we're not put aside as just a transportation business. So sorry.
Yeah, no, that's a great point. And I want to go back to that topic about sort of the value piece, and I'll bring I'm curious about what John thinks about that model moving forward. But before we get there, let me ask Larry, Lakshmi, and Melissa to jump in here, because you will have a different, very area of expertise, and you all seen the expansion of MIH, community medicine, telehealth, ED3. So let me start with Lakshmi. What are your thoughts? And you have a very unique perspective, because in your community, you expanded MIH as a countermeasure to deal with all the disruption. So what are your thoughts about your program, sustainable? Where do you see that fitting in?
So, I mean, I am quintessentially, like John described, part of the yellow state that is not, part of Medicaid expansion, low income, uninsured, health equity concerns, right? Your quintessential urban population with a poor payer mix. So, I mean, we had a relatively robust MIH program even prior to the pandemic, and we did a lot of geriatric, post-discharge, CHF patients that we would go out and visit, and the goal was to prevent readmission. Now, a unique setting difference, I guess, in my case is that I belong to a hospital-based EMS program. So the reimbursement and how that works and the collaboration with the hospital is going to be very different from a private agency. And as far as MIH is concerned, it's definitely to my advantage when we roll out programs, because there is better collaboration with the hospital. And during the pandemic, we did see quite a few programs that we started just purely based on need. Georgia has one of the highest maternal mortality rates. We started a pre-eclampsia program where we'd have nurse practitioners go home and check blood pressures right up to a week to 2 weeks post-discharge for new mothers who could not come into the hospital, check their blood pressure, give them nifedipine, liaise with the obstetrician, see if they needed to come in and prevent readmissions, and basically monitor them before it got too far. We've always had a psychiatric program that goes out and provides mental health resources, but we expanded that for medics to go out and give Invega shots, because we found that a lot of people are just not able to make it for their monthly medication or doses, and then they ended up in the hospital waiting for 3 days, 4 days, 5 days, waiting for a psychiatric bed. I'm sure that's the same across the country. The anticoagulation clinics started going out to get lab draws to see if their anticoagulation dosage needed to be changed. And these are just a few of the programs that started with the pandemic. But if you ask me, is it here to stay? I think definitely a huge component is here to stay. But it is a double-edged sword, because we have to kind of look at, I think patient population selection is really key, because if we end up overdoing it, there's only so many people we could access driving from one space to the other. And we are actually facing a problem where a lot of our psychiatric patients, for instance, are depending on our home visits for their monthly shots. And we are slowly starting to reintegrate them into coming in back into clinic, because it's not a sustainable option either to drive around giving. So it's one of those things, and it factors into their independence, into their social determinants of health. So we're trying to retrain them to actually come in like they did pre-pandemic, to get their care if they're able to. And paid reimbursement. So reimbursement is a huge component of it. And Paul and Randy touched on this, and this is extremely challenging. So if we have a nurse practitioner that goes out there, we bill for it like they would see a nurse practitioner in the clinic, and like a televisit, or if they walked in and saw the patient, we would bill for that. But a lot of times, say for the anticoagulation clinic, where a medic just goes out there and gets a blood draw, or if they go in there to give their long-term psychiatric medication, there is some amount of cost eating by the hospital, just with the knowledge that they're preventing readmissions. And this can be hard to justify in a system long-term, especially given how much we have expanded our roles and how much we've gone beyond just taking a patient to the hospital.
That's very interesting, because in the value piece that we're talking about before, where the fingers are going, that's value added, that the EMS system, regardless whether you are in the hospital base or community base, or not attached to a hospital, it's value added, but it's not captured in this sort of financial structure. Melissa, you've been doing a lot of telehealth, and you've been involved in a lot of these sort of alternative efforts. What are your thoughts here?
Short line, are these programs here to stay? I think, yes, absolutely. I do think we have some struggles. I have worked with a hospital-based mobile integrated health program as well. And I love to say that sometimes these programs are considered as value added to the hospital because they're reducing readmissions. However, in many places, the funding for a readmission is actually higher than the fine of that readmission. So we have had it before. We actually did too good of a job. We reduced the readmissions too effectively, and then our program was actually cut because we cost $1. And here's my lesson, here's my take-home lesson for the day, is that when you save someone $1, you cost someone else $1 of profit. And we have to be smarter about the way that we talk about how we make these programs sustainable. And that means we need to see how we fit into these systems as a whole. Like, we have to recognize ourselves as part of the healthcare system, see where that money is funneling, and then have conversations with all pieces. And I think that's how we make ourselves sustainable. Having dabbled in quite a few programs, won a few of them, lost a few of them, because I didn't recognize the push-pull of the system. So I think, if we, like, part of that is lessons learned, right? Like, how do we learn these lessons is we have to try it. And part of this engagement has to be, how do we start trying? I think for many of us, starting with ET3 style alternative destination programs, those are easy ones for us to kind of integrate because it's familiar territory. It's 911 based territory. And part of that negotiation, I think, is fascinating, is because we can have these conversations with insurance directly. When I think historically, I think of like Medicare driving change in insurance. And I think this is a unique opportunity for us to collaborate directly with insurance to direct change to Medicare and Medicaid. There's nothing stopping a lot of us from having these conversations with insurance companies and with our hospitals and our public health to create kind of funding and sustainability options for ourselves.
Yeah, and that's a great segue into asking Larry to chime in here, because Larry, you've been leading the implementation. So CMS and through CMMI came out with the ET3 sort of program, which got delayed because of the pandemic, but it's trying to get at what Melissa's talking about here, is in trying to find a structure within sort of a big, the biggest payer, but it has its challenges, right? So what are your thoughts on that end?
Sure. So when we implemented ET3 here in Wake County EMS, we immediately were confronted with two challenges: engagement, and then sort of understanding how will this look long-term, sustainability-wise. You begin to offer this new service line to the community. Is it going to be here long-term? Will our patient populations become dependent on this option because it is more cost-effective for them? So as far as just staying power and sustainability, CMS designed ET3 for a 5 to 7 year demonstration project. So we're about 2 to 4 years from its completion at this point. But I think the brighter point, much like everyone else has pointed out here, is that there's been significant progress in appetite from the private payer perspective. Growing market share in our community, we're starting to see a lot of those Medicare patients. It's typically around 20% of our population, starting to dwindle now and shift over to that commercial pile as a function of being a Medicare Advantage patient. So being able to extend ET3-esque or ET3-like interventions beyond sort of the original vision set forth by CMS, I think that's going to be probably the stronger argument moving forward. It's probably a fair assumption that as our society continues to advance in sophistication, the standard consumer will start to desire care options that are not necessarily going to the hospital. They have to be effective, cost conscious, timely. If I'm going to go to the emergency department and wait an hour or 2 hours to see a provider, what's the difference between me doing that at home, leveraging a telemedicine visit, or going to an urgent care? Well, that's probably more appropriate anyway. But the key here is reimbursement. And I know it sounds like a broken record at this point, but without a form source of reimbursement, a lot of agencies that would otherwise love to leverage this program in their community, they're just not going to be able to. So they're going to be relegated to that sort of traditional ground transport to the ED. And the path forward has to be a shared focus on quality and reimbursement. So it's supported and backstopped by legislation. You have to make sure that in an era of value-based care, like John pointed out earlier, you cannot sacrifice that sort of quality outcome for these alternative measures. And as long as we're doing those things, I think we're going to begin to see a shift in a second.
Thank you, Larry. And that's very helpful. And before I go back to John here in a second, I want to ask him a quick question. But I remind our participants to feel free to start putting in your questions in our Q&A box. I'll get to those in a few minutes. But if you have a question that you want to ask the panel, feel free to drop it in the Q&A box, and we'll get to it before the end of the session here. So, Jonathan, I'm curious about your thoughts in the sense of cost containment and still the unknown where sort of healthcare is heading, and sort of what are the strategies to drive that. But you mentioned about underinsurance, and we're seeing here by folks talking about the fact that there's going to be more shift toward value-based care. And so what are your thoughts about sort of this conversation in the sense of how do we achieve both things? And one end, we're doing all these programs that are going to provide, in a way, better care, better outcomes, get to the better access. But right now, the framework doesn't work from a reimbursement standpoint, but it's saving money to somebody else, likely the payers. Do you have any sense in that?
Yeah. So first of all, let me say I've not studied EMS. I've experienced it, unfortunately, personally, multiple times. So thank you, but I haven't had a chance to study it, and I'm really impressed to listen to everything you all are doing. And it just sort of big picture perspective. When I hear you all talk, it it reminds me that sometimes we talk about the fact that emergency departments in the United States are the de facto universal care in this country because of EMTALA and because of the legal requirement. And if you extend that out, in a lot of ways, EMS sounds to me like de facto primary care system, and it's really reflecting the failings we have and the holes we have in primary care and reimbursement. And I mean, to your point, Melissa, the way we put this in health policy is national healthcare expenditures equals somebody else's money. So there is no way to slow down healthcare spending without slowing down income to somebody. And in part, the term value is an elastic one, and everybody likes to use it. And one of the reasons people like to use it politically is it sounds better to say you're going to do value than you're going to cut somebody's payment. So I think, look, there's a lot of, one thing I just want to say about healthcare writ large, we spend so much money on healthcare, over $4 trillion. There's a lot of room here, and a lot of room for EMS. And I think there are, as multiple people said, opportunities to show payers value on the quality side and the outcome side. And I think even though the reimbursement seems difficult, I do want to remind us all that change is possible in a big way. If you went back and looked at the inpatient versus outpatient service patterns in the United States 30 years ago and compared them today, I mean, you would be stunned, right? Because we do a much higher percentage of procedures outpatient. So while in the short term, it seems really hard to shift things, the system or non-system that we have is capable of major shifts. It does happen. And I think there's probably a good, I hate to use this term because somebody rightly said they don't want to have EMS demeaned as a commodity, but there's both a business case and a healthcare case to be made here. And I think it can resonate strongly with payers. And let me just say that many service lines with a less compelling case have a large role in the U.S. healthcare budget. So I wish you all luck.
Paul, so if it's obviously all these programs we think are going to stay, the context of how it's going to look like, it's still kind of unknown. But EMS systems are doing a lot of providing great service, a lot of value, despite this disruptive space we're in. So what advice can we provide to EMS system leaders, EMS clinicians, medical directors about what are the things that we need to be doing now or thinking about to position ourselves to be prepared for those shifts that will have to come?
Well, I think, I see this as an opportunity for us in EMS. And certainly if you're a hospital-based EMS system, which are not super common, it's much, much easier. But it doesn't mean it's impossible for others. And, some of you may have heard me talk on this. I'm a huge fan of advocating for the idea that EMS is probably one of the most undervalued resources in healthcare, because we've always been treated more as public safety than we've been treated as healthcare. And the reality is we're mostly healthcare. We come with blinky lights, but other than that, we are healthcare. And I think it's hard for people to understand just how unique having providers that are lower cost, highly trained, highly equipped, mobile, and comfortable going into a home environment, which many providers are just not comfortable going to a home environment. It's an incredible asset. But directly to your question, what do you do if you? I think mobile integrated healthcare, community paramedicine programs have become much more popular. I think many people have dabbled at the very least. If you haven't dabbled, now is probably a good time to start thinking about that, even if it's not designing value for the larger healthcare system, but designing value for your own EMS system in terms of high utilizers, folks that, your familiar faces, I think Ed Rock likes to call them. Those you can build a system to manage those. I would encourage people as they start out, there's a tendency to build all this administrative structure over the top of an MIH program. And the reality is you probably don't have to do that. You can be very effective with an MIH program using your existing resources with a little bit of training and a little bit of direction. And I think if you can do that, or if you already have it in place, the next step is to go and engage your health system. I advocate for medical directors changing their title to be a chief medical officer because it helps open doors for you as you engage with the health system. But if you can go into your local health system, don't be the solution looking for a problem. Go in and try and find out what are the challenges the healthcare system is facing, and then use what you've already built or what you're building to tailor to meet that. And then the last piece is if you can deliver that value, health systems like ours are looking for ways to do things differently. Try and get a piece of that revenue, whether it's on a per visit basis or sort of a payment for services, sort of as a blanket payment to help support your program. You may not get there with your first visit. I wouldn't come through the door asking for dollars. But once you can demonstrate that value, I think it creates a real opportunity for us to do this differently and have funding streams that support it. In addition to things like ET3, I think that's going to be a big piece of the feds trying to figure this out as well, and finally acknowledging that this is a part of healthcare and driving some funding to us. But there are other ways to do it.
Gotcha. Randy, what are your thoughts on the same lines? What do we need to be preparing for or facilitating to maintain that momentum towards this shift that are happening?
Well, I was thinking when I listened to Paul talk, is that, in Tampa, when I was at your conference, I was inspired by the number of young, fresh faces, which we have seen with today with our three other panelists that can look outside of tradition. One of the things that becomes challenging in the United States is, and we all know that is, if you've seen one EMS system, you've seen one. And many times these become struggled by their own bureaucracy, which is been there forever. So when you talk about doing hospital at home programs, whatever else, it becomes very difficult in some cases because Lakshmi brought this up very, very strongly. There's just a lack of people. You can only cover so much ground and territory. And two, that there are either be state or local ordinances make it difficult to implement these programs because the rules were established maybe back in the 1980s, back when some of you weren't even born. So that requires, I think, for us to go to either at the state level or, as in you said, Paul brought up with our medical directors or chief medical officers, to say the world is changing and we need you to look outside of the box and learn from that. So I think that's one of the key factors. When we've attempted across the country at GMR to do some medically at home programs, some have been implemented very, very easily. In some cases, we haven't been able to do it at all because there are historical rules, territories, concerns, there's liability issues. But ultimately, in the end, we cannot be a system that's based, and I think Melissa said this, and I'm not sure who did, but we're the most expensive means to take someone by the most expensive level of healthcare because they have a cold at 2 o'clock in the morning and there was no other resource. And you can dial 911 and we always show up, but a cab wants $50 for the trip. So that is not sustainable, but we also then cannot be trapped in ways we're in the past and how we're going to fund and exist our systems.
And
And thank God I'm not 40 years old trying to manage EMS. It is such, again, there are so many opportunities. We just need to continue to move forward.
no, it's many opportunities. And Larry, Melissa, can you chime in a little bit about, are there any lessons learned so far? Because I think of all the innovation happening in space, which is, we're in a field where we have a lot of opportunities and we're at different stages in different sectors. But, are there any lessons learned from that we have had from telehealth or ET3, which has been very structured, even though it's been rolled out at different, stages? Any lessons learned from that we should be very, very focused on moving forward? Melissa, you can go first. Yeah.
Absolutely. I think one of the biggest lessons to take away is that this is your system and you know their problems, right? We know our problems. So for example, one of the programs that we initiated was home referral. And this gets back to the question in the Q&A about sustainability, because sustainability is hard. My system has a problem with lift assists. We have a lot of them. We have a lot of elderly people who fall, but this is a great opportunity for us, because what we can do is we can take this lift assist, which is a completely unfunded, unbilled prop up patient, recognize that they're a real patient, do an in-home assessment for, things that make them at risk for falling, do a real medical evaluation, and refer that person directly to physical therapy. And that actually becomes then a treatment in place that's billable to some insurance, right? I didn't have to change my whole system. I didn't have to add a lot of stuff. I do have to train my providers to be, very cognizant about who can stay and who can go. But that's a system that was a problem within my own system that I was able to take and turn into an opportunity to increase billing and funding without adding a lot of cost. And I challenge everyone to do that within their own system. You all have challenges within your own system. Those are each and every single one of those a new opportunity.
Larry, your thoughts, and in addition, are there anything that will come up with the sunset of PHE that would affect these efforts that Bill is talking about, or that we've heard the group talk about? Anything that will sunset immediately that would affect us?
Sure. So I'll just run through the three big buckets of lessons that we learned from implementing ET3 here in Wake County. I call it the 3 Ps of engagement, right? Patient, provider, and the public. Every patient that you encounter might have an appetite for going to the hospital, because that's sort of their base understanding of what EMS does. They come, they take me to the hospital. But if our providers can have that sort of comfort and familiarity with the program, they can better engage in that sort of informed decision-making process with the patient to make sure that they say, okay, well, I can do it telemedicine, or I probably could do urgent care. And then just the general public, educating them on what's going to be more appropriate, what's going to be the new expectation in their system, that when they show up and get an ambulance, they may not always necessarily get its ride to the hospital. They may be offered something different, and just to make sure we don't cause any risks in the general public. Protocol development, it's always big to work with the stakeholders in the system. So one of the things that we did early on was partner with the urgent cares that were going to be participating, as well as our telemedicine vendor, to make sure that we were all on the same page of what types of patients that we would bring them, so that when a provider or one of our paramedics connects with a telemedicine provider or takes a patient to an urgent care, they're not met with that any sort of resistance that would otherwise now damage their ability or their willingness to engage in this program. And then lastly, just monitoring quality. This sort of thing, quality is going to be the focus, right? If we do 1,000 of these interventions and then 50% of them are kicked back, that's not necessarily as effective, right, as doing maybe 500 of them, and then you only have a kickback of 50 of these things. So as far as the sunset of the PHE, the big things, I'm going to speak from the perspective of 911, because that's generally what we do here. But the Medicare ground ambulance data collection systems, that was that sort of big project that sort of is going to take a better look at how EMS is expensed internally and structured internally. There was a bit of a delay there for the pandemic. That's starting to pick back up as the PHE ends. Ambulance treats in place. So CMS was paying for telehealth for those systems that were doing ET3. They were afforded this flexibility. This won't necessarily apply. But if you were not in ET3 and you were performing telemedicine as a function of sort of the community public health response to treat those people in place, that will sunset this year. There may be an additional year. From what I understand, there's some legislation that added an additional year of funding for that. The appeal process, if you have those of us that interact with Medicare administrative contractors for the billing side, there were some filing deadlines, extensions that were put in place as a result of the PHE. Those things will go away, so just pay attention to that. And finally, for the convalescent sort of providers, that repetitive scheduled non-emergency transport, prior authorization process was suspended during the PHE. Once that PHE sunsets, that will go away. So just make sure you're paying attention to the administrative requirements that'll come back so that you're not impacting your agency's bottom line.
Thank you, Larry. That's very, very helpful, kind of a quick summary of that piece. I want to go back. I want to go to a question that we have in the chat. I think Melissa already alluded to, but Leshmi, any lessons learned you want to share with the group that I think is going to help facilitate medical directors or EMS providers systems to be ready for this sort of shift that we're going to be seeing?
So I think Melissa hit the nail on the head with talking about a needs assessment, right? I mean, at the end of the day, what works for a system is going to be what they truly need. And that I think we need to be cognizant about the fact that that needs assessment and the needs of a community also shift. Just because we have a problem today doesn't mean we're going to have the same problem tomorrow. So it doesn't necessarily mean that it's not a sustainable MIH program or a sustainable solution. It just means that it fixed that gap, or it might not be something that we continue on because we don't have that need anymore. So I think as medical directors, we have to constantly have that in the back of our heads to perform a needs assessment and truly try to cater to our community and the needs, which is a forever moving target. And we just need to make sure that we're cognizant of that, and we're trying to do the best that we can to fill in that gap. And a lot of this falls back on the reimbursement. But I mean, fortunately, unfortunately, I think we are at a position where I think it will happen. There's, in addition to ET3, there's a lot of different individual programs that have started up in almost all the urban cities that just come in to do that televisit and to mitigate transports. And they are liaising directly with the insurance company, and they're walking up to EMS and saying, hey, all you need to do is refer the patient to us. We'll take care of the rest. Don't worry about it. It's no cost to you. We take care of everything else. And some even say, you know what, we'll help with you. Whatever money you're losing on transports, we will pay you to make sure we build up our practice system. I mean, all this, like, while I'm not exactly clear on how that works in the back end for them, at least it's promising that if there are so many companies that want to go after it, hopefully reimbursement is expanding to include this, because a lot of this is here to stay. It is a careful selection of your need. It is a careful selection of your patient population. And I think, like everybody alluded to, I think it requires a lot of medical direction, active involvement to kind of decide what would work best, along with liaising with the hospitals.
Thank you. Go ahead, Melissa.
A lot of those systems are liaising directly with insurance programs. And I think it's okay for us as, you know, programs to liaison directly with our insurance programs as well. There's nothing stopping us from having those conversations. And part of that conversation, I empower you to also walk away and say no, right? It's okay to say, hey, I can't do this service for nothing. Hey, I can't do this hour-long visit for $20, right? It's okay to recognize what our costs are and say, we need to be sustainable. In order to be sustainable for you, I need to get blank. So know what you want to ask for when you start that conversation.
Excellent. So we're getting close to our time. There were a couple of questions in the chat I want to get to. So first question, I think, Melissa, you already alluded to a little bit in your prior comments, but I want to open it up to the rest of the panel is, I'm hearing a lot about programs that aren't sustainable. In your minds, does anyone know what a sustainable EMS looks like in the upcoming years? And that may be a 2-hour session answer, but it's a few seconds. Any other thoughts from the panel about that specific question?
I would have, just to jump in, I think in the last 30 days, and you probably, many on this panel, have seen the articles about services that have either had to shut down or significantly reduce their level of ability to respond. So I'm afraid in some cases in America, it's going to just having someone. Sustainability won't be, be an MIH program. It'll just be, is there an EMS system that that is truly going to be effective. And I think we have to be very, very concerned about that. I think that, and it's for any number of reasons, it's staffing, it's reimbursements, all these things everyone talked about. So I think not to fire an alarm off, but it is concerning the number of services that are either reducing or they're just stopping because they can't do it.
All right. So second question here is, and this is for Larry or Randy, you may know, where can we look or find the changes in administration requirements? You mentioned about the power authorizations for those that are non-911. Where can folks look that up?
Sure. So CMS sort of build out a fact sheet specifically tailored to each provider type. If you just type in, PHE ending or EMS or some sort of catch-all phrase like that, that'll sort of populate that fact sheet for you. And that will give you everything far more comprehensive than what I gave. So that's probably the best way to get to it.
Thank you. All right, friends, colleagues, we're getting to our time. So panelists and attendees, being respectful for your time. I know your schedule is full today, so we'll wrap up here. Thank you so much for valuable insight. I think the big takeaway is lots of opportunities in EMS. We're doing a lot of great work, a lot of innovation. We have to figure it out how do we fit that into the new world that healthcare is going to be. We don't know yet how that framework looks like, but we know cost containment and that environment is not going to change. So we're going to have to just kind of work through that. And I think a lot of the tips that Melissa and all the panelists gave about starting to engage specific non-traditional partners into supporting these programs is going to be critical. To all our participants online, thank you for taking the time to attend. And don't forget, if you have any other questions or would like to chat with others, NAEMSP has set a Basecamp follow-up forum to enable you to do so. Participants, you will be receiving an email tomorrow with a link to today's town hall and our resource website. And stay alert for additional webinars in our NAEMSP town hall series. Friends, thank you for your attendance and participation today. Keep up the great work. Be safe, be well. Thank you all.
Thank you. Have a great week.
Thank you.